Okay. So welcome to today's Lunch and Learn. Today we are very lucky to have Mandy Weirich here with speaking today. Mandy is a new faculty member in the School of Social Work. She is our new online program coordinator, which we are super excited about. She also has a lot of experience working with the geriatric population, and I will let her tell you about her past work, and she's going to be talking about contemporary issues facing older adults in small towns, which is a really cool and important topic. So I have just some business stuff to go over first. So for those of you who don't know me, my name is Mary LeClue. I'm the director of the master's program in School of Social Work. So I have handed out to everybody an evaluation form for today's Lunch and Learn. If you can make sure you just fill this out and return to me at the end of the seminar, that would be great. It's very helpful, lets us know which seminars are doing well and just any comments you have about them, as well as what we can do in the future to make these better. If you are a provider and you are interested in CE credits, since they're free and we all like our CE credits, you can come up and get a certificate at the end on your way out. So just don't forget that. There's also a sign-in sheet that's circulating. If you did not sign in, please make sure you sign in. And these are pretty informal. If you have questions, feel free to jump in. And other than that, I'm going to shut up and turn it over to Mandy and let her talk. And that's it. I'll pass it over to you.
How will I know if there's people online? Will I know? I may not know.
You may not know. Sometimes they sort of buzz in or out, but just they can hear you. So,
all right. Okay, so yeah, my name is Mandy Weirich. I have been working in the gerontology area for over a decade now. I guess I can say that. I got my start when I was hired by DHHR in their adult protective service worker field. I had a criminology background, so I qualified for a temporary license at the time. I got hired at DHHR. Really fell in love with adult protective services. It's just probably the most gratifying work besides this that I've ever done. It was just really eye-opening to a whole population that, other than having grandparents and that sort of thing, that I just didn't know all the complexities and cool things that were out there. So I worked through my temporary license. I decided to go back to school. Got my MSW here at WVU, focused on gerontology. Got the Gero certificate. Then I transitioned to become the statewide trainer for adult protective services and adult services. Did that for 4 years. And then just recently, I was the program manager for Healthy Home, which was a grant-funded project in Randolph County and Tucker County, in which we coordinated care for seniors that lived in congregate housing, so low-income senior housing in Tucker and Randolph County. And our job was to make sure that folks had the services that they need. We did social activities, we did weekly visits, and that sort of thing to help improve their lives, but also to help reduce their healthcare costs and the healthcare costs of their insurance companies. And in 2.5 years that I was there, it was incredibly successful. The impact we had on their lives just by being a person of support and an advocate and a voice right there in their apartment building where they could reach out was significant. It was so low tech, so easy to do, and had such phenomenal results. It was just amazing work. So I'm hoping we were seeing those kind of projects pop up around the country, and I hope to see more of that in West Virginia. And we'll talk a little bit more about that as we go through. So, do any of you have questions for me before we get started? All right. So, oh, and I guess I should say, well, now I work at the School of Social Work, and anyone that interacts with me at some point in our conversation, I'm going to bring up seniors, gerontology, aging, and all of that. So hopefully my influence in this program will carry forward, and we'll have many, many more people in this field, because it's very important. So we'll go through a couple of points that affect seniors in our communities, and then we're going to look at some case studies and kind of talk out the issues that I'm going to hit here. So social isolation, this is pretty huge. Social isolation can occur in a building full of people, an apartment building where you're surrounded by folks, and it can happen in houses way out in the country where there's nobody for miles. It can happen in neighborhoods, it can happen anywhere. So it's not a matter of are there people around, it's a matter of how interactive that person is with social supports. A lot of times it comes about with health decline. If you're not able to get out, embarrassed by your condition, you don't have family support to help make those links. Maybe you just don't even have the equipment to get you from your house out to where you need to go. Many, many things factor into social isolation. When seniors experience social isolation, it is linked to poor health. I mean, you can kind of imagine that snowball effect of they start to decline, they don't get the help they need, they decline more, and it's just kind of a rapid de-escalation there. And we are social creatures. We like people around. It makes us feel good. If you are sitting in your living room day after day after day looking at the same walls, not just through the winter, but through all 4 seasons, with very little interaction with people, maybe the TV is your only interaction, maybe it's a few animals, you know, you can imagine just the depression, those feelings of isolation that would just kind of feed off of each other. So we do need social interaction with others. And our systems are really not set up for us to interact, right? We're a very isolated civilization. We drive cars by ourselves. We don't use mass transit, except maybe here in Morgantown they have mass transit. We are very independent. We move out of our parents' houses. Some at 18, some a little later than that, but as the trend is. But typically we live very isolated. You have your snowbirds that leave and go to Florida to live, you know, all winter down there where maybe they don't have their family support. Or you move away to another state for a job and your parents or grandparents are left here. So our systems are kind of set up that way. Transportation, we'll talk a little bit about later. You know, we've built our communities and roadways in a way that it's really not easy to get where you need to go unless you are very, very mobile. AARP, they have some really great resources, a lot of briefs on their website if this is something that interests you. And they have some studies out there that do link social isolation to increased healthcare costs. Their study focused primarily on Medicare, but you can see the same result would be with Medicaid or any other private insurers. Because once you start to decline, your trips to the emergency room in an ambulance for lots of tests are going to increase. And there's not a test for social isolation, right? You're going to be tested for all these other things. And sometimes it's just a matter of this person doesn't have a connection to the world. And they don't know how to advocate. They listen to the doctors speak all this stuff. You know, they nod their head. They may or may not even hear what the doctor is saying. And it just kind of spirals. So at a certain point, they're really going to be good if they can be stable and not decline further. Sometimes they get to a point where they're not going to get better. So, it's not unique to West Virginia, obviously. It's all over the place. But what barriers do you think are unique in the Mountain State? What would contribute in West Virginia to social isolation? Lack of transportation. Lack of transportation, yep. Poverty, in what way?
Because if you don't have money to travel somewhere, even if you live here, you don't have the money for the gas, you don't have the money for food or whatever.
Yeah, so I don't know if her voice picked up on the microphone, but she said poverty because even if you have transportation, you may not have money for gas or food or for travel. Absolutely. I know at the height of, I live in Elkins, I know at the height of the gas prices at almost $4 a gallon, my radius was within 20 miles of my house. So any trips outside of that were just not doable. So you can imagine on a fixed income, you're going to keep your circle very small. So specialists might be out of reach. You may be able to go to your local hospital, your local physician, but any kind of specialty doctors may just not be doable unless you are on Medicaid. And even that has problems with transportation. Any other issues in the Mountain State that would contribute to isolation? Geography, huge impact on isolation. Those mountains, I mean, you're either on this side of the mountain or that side of the mountain, and that, you know, access to care is going to be determined on where you live and who can get you there. The other thing is, you know, we've heard a lot about our roads recently in the news, and that is definitely of concern. The shape of our roads. If you have a very old car, that maybe you do have the gas money to get where you need to go, but you know, are going to really tear up your car to get where you need to go. But you can't go in the winter. Maybe you can go in the summer months, but the winter is just a no-go. And what happens when you cancel doctor's appointments? You may just not be allowed to be a patient anymore. So if you cancel, that's also an issue. And I'll say this here, I can't remember what the next slide is, but even folks that are really sick are often too sick to go to the doctor. Like the actual getting up, getting clothes on, getting in a car, even to travel just a few miles can be so overwhelming and just impossible, even when they're very sick and really need to go to the doctor. And so they do end up canceling those appointments or not, you know, even if they have transportation, maybe just not even being able to get out there to that vehicle to go to their appointments. And so then again, it just kind of creates this spiral. They can't get another appointment for several months, or they have to use urgent care or the ER when things get really bad. But folks that are too sick to go to the doctor, it's not that they don't want to go. It sometimes just feels physically impossible or even just mentally impossible to make it happen. And so that also contributes to that social isolation. Next thing I want to talk about is food insecurity. This is huge in our state. It's big everywhere, but it is quite significant in our state. And with prescription drug medicines going up constantly and income not going up, this becomes even more of a problem because our seniors are even trying to choose between whether they will have food or whether they will have medicine. Getting out to get food, again, just as overwhelming as trying to get to a doctor's office. If you've never done this, I recommend it. Go to your local grocery store and get into one of the carts that are for people that are they're like wheelchairs. Some of them are like wheelchairs, some are like scooters. Go through Walmart or Kroger in one of those and just experience that, because it's not as easy as it looks. It's overwhelming. You feel the judgment as you go through the store. Things are difficult to reach. People don't help you. It's quite the experience, and I would encourage every one of you to do that just to see what that's like. So if you have COPD, congestive heart failure, those diseases that might not be visible to the outside world. It can be a real barrier to even going to the store and getting food, because you're only going to get enough food that you can carry into your house or put into the trunk of your car yourself. It's not like you're going to go for the big trip, right? Like you might if you're younger with a family. You're just going to go get the few things that you need. And then affording those foods. A lot of seniors that are on a fixed income don't really qualify for SNAP benefits. In West Virginia, they're able to, every state's a little different. Sometimes they're able to get them qualified for maybe $15 a month. So they get the SNAP benefit and then they get help with their utilities. But $15 for extra for food is really not significant. And anytime those benefits go up, you lose help like with rent, or you may lose help with your Medicare premium. So any increase in Social Security, there's not extra money in the bank, because it will go away some other way for people that are low income. So there's never an opportunity to kind of overcome your financial problems there. You're never going to have more for food, really. There are food banks. There are food banks and food pantries. In our community, we have these blessing boxes that people can just, they're just set up around town where you can put food in and people can go and get. But again, try to get to those. Try to get to one food bank when they're open, because sometimes they have they're open 1 to 3, and then you have to be at the housing office at 2. Try to get to those places with a ride, because you can't drive, and see how much food you actually get and how you have to prepare that food. You have to open cans. You said like bags of dry beans. I mean, that's all food, and it's great that it's out there, but how accessible is it for someone that has issues with arthritis, that can't maybe carry some of those boxes of food out to even the car? So a lot of folks just make do, cereal, canned foods, or just don't eat. Meals on Wheels, they're really great, but a lot of times they're limited to where they can deliver to like a small area, so they're not going way out to the country and those sort of things. So there's little pockets of help, but even just navigating all of that, and especially if you're dealing with depression and you're just chronic disease alone, and then also trying to navigate these systems, it just kind of piles up, and a lot of our seniors just go without. It's just easier, and we see that a lot. And they don't necessarily talk about it, and they don't necessarily report it to their doctor, but it's definitely happening. Also in West Virginia and other areas, we have food deserts. These are areas with a limited supply of fresh and affordable food. So basically a grocery store, right? A lot of convenience stores out there where you can buy junk, but not really a well-balanced meal. And so that's considered like a food desert. Being in Morgantown, it's hard to think of, I don't know where one would be, but I bet you if you drive even to Preston County, you'd be in a food desert real quick, trying to find access to food. So that's also a barrier to food. I work with clients that they basically spent their food money at Sheetz. That's where they would get most of their daily meals. I mean, they might get some food from like a food pantry or something like that, but their regular meals are coming from Sheetz. And if they have diabetes or some of these other chronic diseases, I mean, again, it just kind of feeds the animal of poor health and just poor quality of life, really. Real uplifting, huh? Just again, talking about the home delivered meals. All right, touched on these. See, I'm ahead of myself. All right, transportation. I mean, transportation has been a problem probably as long as there's been transportation. It's a huge barrier for adults with disabilities and for many older adults, especially if they have a limited income or significant impairments. I mean, it just, getting in Morgantown, you have mass transit where you have buses. How do you get up on the bus if you have arthritis in your knees? Or are you using a cane but also trying to carry your groceries? I mean, I guess some can do it, and they do it, but it is very, very difficult. But a lot of our communities in West Virginia, they don't have mass transit, and they don't have transportation. Some senior centers have vans that can go out and do some transportation. Often it's limited to non-emergency medical transportation. And that's where Medicaid will pay for you to go to doctor's offices and the hospital. But it doesn't allow you to go to the grocery store or the drugstore or all the other places you need to go for your health, right? I mean, the doctor's office and the hospital are not the only places that influence your health. And NEMT does not pay for you to go to those places. So that's definitely a barrier to transportation. Some of the in-home care providers will allow their workers to become NEMT providers, and then they can drive their client to the doctors and get reimbursed mileage. But a lot of those workers don't want the hassle of the reimbursement for that, or, you know, it's just they don't have enough workers to do that kind of service for all the people that they're serving. So again, it's another barrier. Have any of you ever been in a situation where you didn't have a car and you needed a ride to work? How hard is it to ask people to give you a ride?
Well, because you feel like you have to apologize for asking for something that you need to have.
Yep, it is very difficult. And your schedule might infringe upon their schedule, putting them out. I went through that for 2 months several years ago. I didn't qualify for any of these services. I lived just far enough out of town. It's very, very difficult to ask somebody for transportation. And often when seniors don't have reliable transportation, this just kind of plays into the social isolation. They don't want to ask for help to get to where they need to go, so they just stay home. They do without food, they do without medicine, their health declines, they end up in the ER, and then it just kind of starts all over again. And they're not going to tell the doctor that. They're not going to tell the doctor why they missed those appointments. They're not going to tell the doctor why they don't have their medicine or why they're non-compliant for food or for taking care of themselves. They're not going to tell them all of these things. They're just not going to do it. And then the doctor just treats the symptoms. Accessibility, I touched on this a little bit already. Again, I would encourage you to go to a place where you had to be in a wheelchair or use a walker. Go to a place that has a ADA ramp and try to push yourself up one of those ramps in a wheelchair, or go down, because that's even more exciting. And I bet you will find they're really not built for people that have accessibility issues. We see this in a lot of our places. Hospitals where from the entrance to the information desk to the office that they need to be, how many steps do you have to take to get there? And how do you do that if you can't breathe? And how do you ask for help? These things just kind of build. West Virginia, we have a lot of old buildings that have not been modified for people to be accessible. They're not accessible for people in wheelchairs, walkers, canes, or with strollers. They're just not accessible to anything or to anyone that has any mobility issues. I would really love to see people in design and city planning just really embrace accessibility. Because if you make it accessible for someone in a wheelchair, you're really going to make it accessible for everyone across the whole age span. And it just makes you rethink how it should look. If you think about homes, I'm sure you can go through any neighborhood and see ramps built out from a house, right? And so what does that tell you as you drive by? They're in a wheelchair, they're in a walker, they're vulnerable. It's like a big sign that says there is someone vulnerable that lives here. Makes a real good target for any kind of criminal, right? What if all of our homes were just accessible and you never had to build a ramp because you could just always get in? It just takes a little bit of innovation and maybe spending a little bit more money up front. How am I doing on time?
You have 11:56.
Access to healthcare. So when I went into adult services, kind of going back to that, was in 2008. So pre-Affordable Care Act, right? A lot of my referrals for neglect and self-neglect were because people didn't have access to medical care. They just, they were maybe in their 50s, early 60s, not quite to the Medicare age, certainly didn't qualify for Medicaid at that time because it wasn't available to them unless they'd had a disability for a couple of years. They couldn't work because of their illness or disability. So they were just stuck. Medication, out of pocket. It was tragic, really, to walk away from a human being knowing that it was just up to fate what happened to them because there was nothing. So the Affordable Care Act came along. It opened up Medicaid to that population. Really, really helped folks, truly. Even with all the problems I've described so far, the Affordable Care Act that gave those seniors access to health care significant. Because now you can get them linked to a doctor. Now you can get them, prescription drugs. You can start addressing those things that they're dealing with in their life. So it was huge. We've also seen that with the Affordable Care Act and having access to health care, people with chronic disease having early intervention has significantly improved their quality of life and their health and has reduced healthcare costs. Because if you catch diabetes and treat diabetes in your 40s or 50s, then you're just not dealing with the problems at a high level in their 50s, 60s, 70s, 80s. I mean, it's been being managed versus someone that has gone without care for years, and now they're in the emergency room, they have sepsis, they have to have their foot or leg amputated, and then the quality of life for that person and the healthcare costs for that person is just skyrocketing. So the difference in intervention early, access to medical care early, is significant. So I can tell you from personal experience that the Affordable Care Act has improved the lives of thousands of people in West Virginia. And I can assure you across the country when they have access to medical care. And in West Virginia, we all know that we're not very healthy, right? So we have very high rates of congestive heart failure, COPD, diabetes, big three. So early intervention is very important. Housing, and in particular, affordable housing. Quality housing, all those things, there's not much out there. West Virginia has the highest rate of home ownership in the country, the last I checked, but most of those homes are at least 50 years old or older. They're not in good shape. Most of them are not accessible. So what happens when you're living in a house that's 70 years old?
Needs updated.
Needs updated, needs repairs. Have you ever tried to put a roof on the house when you made $800 a month, Social Security? Or get a loan when you're only drawing about $800 a month? Or trying to find a contractor that will you put on a roof? No matter what age you are. So you can see where there's a lot of problems here. So we have these seniors that are sick, don't have access to good quality food, may not have access to medical care or transportation, and now they're living in a house that's going to need some work, or they're just kind of patching over things. I'll use my grandmother as a personal example. In her bathroom, the tiles were coming out of the shower, so her solution was she stuck up clear plastic with duct tape over the tiles. And I'm just like, there's no water getting behind the wall, it's fine. So they do these things, or they're sitting in their recliner and the ceiling is bowing down almost to the top of their head, and you just pray that that's just not going to give, or the black mold has just spread across the ceiling and down the walls. At Adult Protective Services, you see a lot of really, really bad houses. Foundations caving in, so it's like the house is sinking, but they just got a brand new hospital bed brought in. They're gonna try to make it work. And even that home ownership, I had one particular case that technically she owned an additional house other than the one that she was living in, and it was in that kind of condition where it was falling down. Like, she can't rent this, she can't sell it, it's been on the market forever. And she was denied Medicaid because she had this extra asset that was just sitting there. So there's a lot of issues that come into affordable housing. So if you've tried to hire a contractor recently, you know that there are very few workers out there that are building houses or fixing houses. It's very difficult to get things fixed up, but we just have a very low housing stock. Trying to bring jobs into our state, but you don't have houses for people to live in, or houses that they want to live in. Not everybody wants to live in a 100-year-old farmhouse. They want something that's updated and new, and you're not going to have problems with it. So housing is definitely a challenge. And not just here, it's everywhere. So just to touch on a few resources, there are a few more, but what we find is most resources for seniors are tied to healthcare. So, or to your Medicaid card, I should say, or if you have Social Security. That's when those folks that aren't quite 65 yet, sometimes they fall between the cracks where they don't have access to certain benefits out there. So it's a little bit challenging sometimes to link services with seniors. You got to be real creative. I have to say our faith-based communities are really fantastic for the most part. They really try to fill those gaps. And there are a lot of gaps, but there aren't a whole plethora of resources for seniors. They're kind of limited. But some that you have, 211 is the information line, referral line that you can call, kind of explain what you need, and they will try to connect you to the service. The Age and Disability Resource Network is specific. It's also a referral service, but it's more specific to that population, whereas 211 is for anything really. Your local senior centers, a lot of them are really good, and if they can't provide the service, they may be able to connect you to a service provider in your community. Every county has kind of a different level of senior center services. Some are really tiny, and it depends on what county you're in. I did put adult services on here because they do more than just investigative abuse, neglect, and financial exploitation. They're really the resource to go to because they do it all. Every day, they are making referrals. They are solving a lot of these issues, and they are really, really good resources to just call and say, hey, this is what I'm dealing with. Do you have anyone that can help in this situation? In some of those situations, especially if it's self-neglect, may require a referral and APS to go out and kind of work through that situation. But sometimes they're able to just kind of give advice over the phone, or at least put you in the right direction as far as resources. And then the last one I put on here is supportive housing, and that goes back to what I was talking about when I introduced myself. Supportive housing is a new trend where in these low-income housing sites, they do have coordinators or social workers. Sometimes they have nurses that are in those sites to kind of help with these coordinations and get people into the services that they need. Lewis County is trying to start one. Well, they have started one. It's just getting off the ground. It's a collaborative effort between like their senior center, the hospital, health departments, a couple other folks in one low-income housing site. One in Randolph and Tucker County, they're still providing that service at several apartment complexes. And then in Vermont, it is actually statewide, their SASH program, where they have supportive housing for seniors. And it's, like I said, it's a low-cost, low-tech intervention. It's just really a formal support that folks need as they age. It does become more difficult once you get out of like a congregate setting, like when you're going house to house, because in a congregate setting, you can sometimes address like a bigger population all at once with services. So there are things about it that don't work in every kind of neighborhood, but it's definitely a phenomenal way to address these issues. So the next part, we'll finish out with our case studies. I passed those around earlier. There's one on each side of the paper. For those online, I'm just going to pull it up here. This is the case of Miss Young. Should I read this out loud? Yeah. Okay. All right, so Miss Bonnie Young is a 73-year-old woman living near a small rural Appalachian town. The town lies in a valley at the intersection of two-lane highways, each winding up and away into the mountains. The town has a gas station that sells some food items, a mechanic, a small senior center with limited services, a pharmacy, and a K-12 school. The closest grocery, hospital, and physician are on the other side of the mountain, about 40 minutes away, in good weather. Miss Young has lived there her entire life, has a high school education, and owns a home built in 1920. She feels very grateful to be on few medications, one for arthritis and one for blood pressure. A widow, Miss Young draws about $1,000 a month from her deceased husband's Social Security, receives $15 a month from SNAP, and gets 20% off her electric bill. After paying for her second mortgage, utilities, and phone bill, this leaves her about $300 a month for food and household goods, home maintenance, medication co-pays, insurance deductibles, vehicle maintenance, and other expenses, much less a birthday gift for her niece. A few years ago, she was able to install an electric heater in her living room because the cost of oil heat for her whole house was too much. Now she mostly stays in the living room because of the warmth, preferring to sleep in her chair than in her bedroom. House repairs in her home continue to worry her. She knows that there are repairs that need to be done, like a new roof, but she does not have the income to take on such costs. Her primary concern, though, is her bathroom. It was installed years after the home was built and is very small. Duct tape holds up the tiles in place, but water is surely getting behind them. The toilet wobbles and is very low, which makes it difficult for her to stand up with her arthritic knees. Ms. Young has heard of low-interest loans that may be available through the local community action program, but she doesn't believe she could repay a loan. Last year, the local church youth group helped build a ramp onto her home, which helped tremendously to bring in her groceries. Unfortunately, the youth group cannot help with the bathroom repairs. Ms. Young's sight is getting worse too. She worries how she will be able to get out to the doctor and get her groceries. Her neighbor has offered to drive her to the store a few times, but is not reliable because of her own health problems. Ms. Young knows the Lions Club can help with new glasses, but she's too embarrassed to ask for help. After all, she is sure that there are others that need the help more than she does. So what are some options for Ms. Young? Adult family care?
If she were willing and able.
If she were willing and able for adult family care, yep. That's a resource through DHHR, Department of Health and Human Resources. It's similar to foster care in that you would go and live in someone else's house. They get a stipend from DHHR to make sure that you have a room to live in and you've got food and transportation and those kind of things. But you have to also pay your portion. I'm sorry? Anybody else?
Any sort of like service provider agencies, CCIL, that's available in the area. But
CCIL or in-home care, yes. I mean, that could be an option. Sometimes there's up to a year wait for in-home care. Currently, I was just told today that there's no wait, so for age and disabled waiver services. So if you apply, they're getting them in right now. So it's a PSA. But sometimes people do wait a year or more to get that service.
I mean, you can offer her all the help in the world, but is she willing? This says, she doesn't even want to do, even the Lions Club glasses thing, which is an invaluable thing for her to hardly see. But she didn't want to, because surely there's people who need more help. If you have that mentality, it's going to be hard for you to accept any kind of handout.
Yeah, and in our culture, it's hard to accept a quote-unquote handout, right, or help. Either it's embarrassing or you think other people are going to need that help more than you do. So, again, you're going to suffer in silence, right?
That was something I was going to say, especially with older generation, there's a stigma against asking for help.
Yes,
Especially with older generation.
I agree.
She let the church youth group help her though.
She did let the church youth group help, but maybe she just feels like she doesn't know who to ask. Is there anyone that she could ask? Do you know?
Go to the senior center first. What's out there?
Start with the senior center. Even if it has limited services, they might be able to connect her with a bigger senior center or other service providers. They might have the list of services available in her area. Any questions on that one? Yes.
Is there a certain way that you can, because she's afraid to ask for help, is there a certain way you can have that conversation to get them to understand if it's okay to take help sometimes because we really want to help you kind of thing? Is there a way to have that conversation? Because I'm in a similar situation with my mother-in-law sometimes.
It's always different with family, I will tell you that. Yeah, I mean, sometimes just kind of knowing that there are sources out there. If you can also say, kind of point to other people that receive those services, so it's more like the norm. sometimes it's a slower process where you start with, well, there's this out there. And then maybe next time you show them kind of a list of the services that are out there. And hey, wouldn't it be nice, if you had those glasses, maybe you could read more like you used to. I mean, like, so sometimes you got to go slow and easy. And other folks just need to kind of know that it's out there. And then they're like, oh, I had no idea that this was even available. So everyone's just a little different, and you just kind of have to feel your way through that process with them and be okay with them to say no at first. And then there's ways that you can just kind of bring it up in other conversations. And I tend to just talk about other folks that have benefited and just kind of put it out there. And I personally have used social media. If there's somebody that uses social media, sometimes I'll repost things that I see where people have benefited from certain services, or even I'll just kind of write out the benefits of certain things so then they can kind of take it in their own time. If it's like a family member or something, but yeah. But yeah, there are some people who are going to shut you down until it's so bad that, they're in bad shape. Definitely have had people that they weren't ready to accept help until they were in a hospital bed at the hospital, and until they were kind of forced into that situation. And it's really sad.
And it's hard because you can't do it for them. Like in domestic violence situations, for example, I can't go and say somebody beat the shit out of Amanda. Amanda has to do that herself, and people don't understand that. It has to be, you can't do for somebody nowadays. They have to take that step way through themselves, guide on it.
Absolutely. And as social workers, respecting their dignity, respecting their right to make their own decisions, their right to self-determination. As helpers that we are, it can be very frustrating and very difficult, because especially when a resource is right there within grasp, right? But you just have to give them the information and offer to be there to help them through that process, and let them decide until they can't decide for themselves. So especially with seniors, sometimes it gets to that point. Got some competition.
I know.
I use a lot of motivation. If anybody knows about that, like research that is that's it's kind of manipulative, like it's
Persuasive.
It's the people where they do it.
Yeah. Yeah, motivational interviewing is a good resource for social workers and other providers to use. And having the time to do those things is important. I mean, this is not like a rush job during your 15-minute doctor's appointment. These conversations take time. Because sometimes there's even communication barriers, like, hearing, or they have to it takes longer to process the information and all of those things, or they get distracted.
Even our elders know stranger danger.
Yes, that's another great point. I'll just, we often say if we could get someone to come in the home to help, that would alleviate a lot of the problems. But on the other side of that is trusting a stranger to come into your home. That's a very intimate situation. They're in your space. They're going to know intimate details about you, and you have to trust that they're not going to steal from you, or they're not going to lie to you, or any of those things. So, and even just with a service provider, trusting that the information that they give you is good. That takes relationship building and time. Did you want to add anything onto that? Because you kind of mentioned it's an excellent point.
Just that we have a case now where the elder, heck no, she's not going to let anybody in her home, and she brags about that. blocked from the outside, and you know, if it's blocked from the outside, there's no entry.
Right?
It's just, it's frustrating, because we have to keep it as a case, but you can't get to them and do what you're assigned to do, because they have this stranger danger fear.
Yeah. And perfectly reasonable, in my opinion. I don't trust people.
And so it's shutting services down.
Yes.
Because she's like, you know, she hadn't been a doctor God knows how long, and practitioners just were done.
Yeah. Yeah, and they burn a lot of bridges, and that can happen. And that's why they need folks that are going to even speak up for them, even when they've burned those bridges. And that can be very challenging. Let's look at Mr. Singer real quick, because I think we're wrapping up time, right?
About 9 minutes.
About 9 minutes. So his is just a little bit shorter. Get it on the screen here. So Mr. Dale Singer is a 70-year-old divorced man who lives in a low-income senior housing building in a small town in rural Appalachia. Mr. Singer is no longer able to drive, uses a walker, and needs help in his home to cook, clean, and bathe. Mr. Singer was diagnosed with diabetes a few years ago, but finds that it's difficult to manage, and he doesn't always understand what his doctor tells him. He is concerned about his feet because they hurt and tingle, and he can't imagine what his life would be like if he ever had to amputate his foot. Mr. Singer sees other people in his building that have lost feet and legs to diabetes, and it worries him. Mr. Singer pays a neighbor to take him to the grocery store once a month for groceries, which doesn't always last the entire month, but he gets by, and he knows others have it worse than he does. Mr. Singer finds himself staying in his apartment more and rarely goes out to visit his friends and neighbors. He worries about falling. He doesn't like for people to see him struggle with his walker, and he knows he needs help, but he doesn't want a stranger in his home because he fears they might steal from him, and he isn't even sure who he would ask for help. So do you think Mr. Singer is isolated? What do you, if there's no intervention, what's going to happen with Mr. Singer? Gonna die? Diabetes is going to contribute to that? Sorry, it's really hard for me to hear.
I said you have to have a specialized diet when you have diabetes. You have trouble getting to the store.
Yes.
Much less a specialized diet.
Yes. So already had trouble getting food, but a specialized diet for diabetes even harder. I mean, you got to learn how to recook everything you've known how to cook, right? I had one lady, she's like, she cooks with butter and lots of it, right? That's the only way she knows how to cook. And a diagnosis of diabetes is probably not going to change that. Because she's just always been that way, right? So learning to recook everything at that age and shop for those recipes, do recipes that, you know, call for these special ingredients, do they cost more? Probably.
You know, as good as like poor fat, you know, like 99-cent cheeseburger for pounds. It's cheap, you know, but it's so unhealthy.
Yes.
So a lot of what these foods contain, you know, high fructose corn syrup, stuff like that. That's stuff that I would stuff that is affordable at time.
Yes. So he's got a couple marks against him. What do you think we could do for Mr. Singer to kind of help him out of this situation? What are some resources you might have?
Just wheels cater to diet plans.
Some do, some don't. And the question was, do Meals on Wheels cater to diet plans? It just depends. Some, it's just whatever's on the menu, but there are other organizations that will cater. How about this side of the room? Any resources that you would connect Mr. Singer to?
Appropriately kind of that is a have like online printouts that are more, they're simpler terminology, help explain the food that might help better, instead of printing off material for him to see in a more simple way. The Meals on Wheels Senior Center, maybe someone to come in to help with like house cleaning, 2 hours a day, with socialization, things like that. Connecting with transportation systems. I don't, obviously not where he's at, but even in Preston they have Buckley, things like that. So there's and he's already in a building from senior housing.
Yes. And I'm going to say that she hit the nail on the head. A social worker that can translate all that for him. We really need to be aware these folks are telling us things when they're not telling us these things. We need to ask the right questions to really get to why he's canceled doctor's appointments. Why is he not coming? Why is he not being compliant with his diet? Go beyond the assessment, go beyond the computer screen. Build that relationship so that he feels comfortable saying to you, you know, I'm really scared and sometimes I really don't understand what I'm supposed to do. I'm really scared of losing my foot, but I don't know how to make it right. And then from there, you got something to work with. But if you can't get him to talk to you, really tell you, you're not going to be effective. And so I would say, let's put this back on the social workers and the professionals and the provider offices to really rethink how they interact with their patients when they come into the office, or the housing manager when they come down to pay the rent, to ask a few more questions, or all of us out there that are interacting with our seniors to just take a minute and really see what's in front of us. Not just make sweeping assumptions and chalking it up to non-compliance. If we could just erase non-compliance from the vocabulary when we're working with people, that would be fantastic. Because people are making choices for themselves.
And on that note,
yes, on that note, I don't think I can compete with the guy on the megaphone any longer outside. I appreciate all of you coming out and spending your lunch with me. I hope it was useful to you. If you have any questions, let me know. I'm at the School of Social Work. I don't mean to be doom and gloom, but really kind of doom and gloom a little bit.
so thank you, Mandy, for that great talk and for competing with the megaphone at the end. We
Yes.
appreciate it. And thank you all for coming out. If you can all just make sure you complete the evaluations and bring them up. If you need CE credits, come and get your certificate on your way out. And hopefully we'll all see you back here for next week. We have another Lunch and Learn. I believe the topic is social enterprise. So
Yes, I can't wait for that.